The information in our presentation today was developed by several experts in Ontario Health, Public Health Ontario, and researchers at Ontario universities. All of this led by the COVID-19 command table. Our objective today is to share the modeling and projection data that command table has been using to inform our work and has been using to advise government on their response to COVID-19. We feel it's important to be transparent with the public about the scale of the challenges which together we are facing and the important work that we all need to do to help flatten the curve. How this outbreak unfolds is in the hands of the public, in effect, in all of our hands. We can change the outcome for the province by staying at home and physically distancing ourselves from each other. Now, recognizing that we get new information about this virus and this outbreak on a daily basis, we will, of course, continue to refine our projections, our models, and our advice. Everybody should take reassurance from the fact that our public health measures so far have made a significant difference. And we need everyone to stay focused in the weeks ahead. So stay home, stop the spread, and stay safe. For media following along with the slides, I'm now turning to slide 4. There have been 67 deaths in Ontario. I appreciate that some people may see different figures from that, but those are the figures that have been processed through the integrated public health information system. And although I can fully understand that it may appear confusing or even frustrating for some members of the press when they hear about deaths reported in the media locally, it must be frustrating when the deaths count does not quite tally. But it is important that you understand that the correct way to track this over time is through the Integrated Public Health Information System, IFIS. There will just be a little lag as hard-pressed public health units insert the necessary details. The thing that is striking from the data that we thus far have in Ontario is the high mortality rate in those over the age of 80. Thus far, it is 16%. That is actually a little less than global experience, where the evidence from around the world suggests that the mortality in those over the age of 80 is actually 20%. The mortality in those over the age of 70 globally is also significant at around 10%. These are very important figures for us all to be familiar with, because it tells us that we must focus on protecting the elderly. On the next slide, for the media who are following along, you will see COVID cases in Ontario tracked against those in other countries and other jurisdictions. The thing that I must draw your attention to is the fact that there is a logarithmic scale along the left-hand side of this graph. And of course, what that means is that a small increase in the graph equates with a very large number of increases in cases. Nevertheless, in an epidemic situation, this is usually the most useful way to track the progress of a disease. And as you can see from this curve, we are following a trajectory somewhat similar to that in the United States, not quite as good currently as that in British Columbia. But I would hasten to say that when one tracks cases, it really is rather difficult to know exactly where you stand. You have to watch it extremely carefully because it is rather dependent upon who you test for the disease. If I turn to the next slide, we are tracking deaths. Now, sadly, deaths around the world are mounting. And one of the things about tracking deaths as opposed to tracking cases, they are not subject to the same complications that are brought about by differences in testing strategies. And so here again, you can see that we appear in Ontario to be roughly in line with the rest of Canada and to be roughly in line with the United States. But of course, once again, we will continue to watch this extremely carefully. It is important to acknowledge at this point that a great deal has already been done in this province that will help limit the eventual death toll from COVID. So if, for example, we go back as far as March the 12th, we had the closure of public schools. Rapidly after, there have been a series of other measures. For example, limiting visitations to long-term care, looking carefully at those who are in short-term in and out arrangements with correctional facilities, and prohibiting large gatherings of over 250. By March the 16th, people were being told to practice social distancing. Travelers from outside Canada were being told to self-isolate for 14 days. The prohibition on gatherings was dropped to 50. And people were told to work virtually wherever possible. By March the 17th, we had the closure of public gathering places and establishment. By March the 21st, redeployment for healthcare professionals. And then rapidly in succession on the 23rd, 24th, and 25th of March, the closure of non-essential workplaces, work deployment for LTC homes, and the prohibition of gatherings of more than groups of 5 people. Most recently, we have seen enhanced capacity for contact tracing being rapidly put in place. We have seen the closure of parks and outdoor recreational facilities, and people have been instructed to limit outings to essential needs. Self-isolation for individuals over 70 and those who have underlying medical conditions or who are immunocompromised has been very strongly recommended. We also have had extended school closures. I'm now going to pass across to Steny Brown.
Thank you. I want to just start on slide 9 for those who are following on with slides and talk a little bit about some of the caution with which any models need to be interpreted. They're really used to help us plan what could happen. But, you know, I say this with very great seriousness, they are always an abstraction of what we're dealing with. And the farther out we go, the more uncertainty there is. We've used assumptions based on what we've seen in other outbreaks of COVID-19 and what we can gather from data around Canada as well to try to inform the model. And then we model how it spreads. And we do this based on standard epidemiological models where we can, We try to make assumptions about how quickly, or make estimates of how quickly and how widely the disease will spread. Critical to say that we'll talk about what would have happened had we done nothing. We'll talk about what may happen now, given the public health interventions that are in place. And we'll also talk about what could happen if we had enhanced measures to continue this or to try to suppress the disease as far as we can. It's important to note, though, these measures only work if people follow them. And so the assumptions that are in place here are assumptions about people working to make sure that they stay safe and keep the people around them safe. And it's important to note well that if there are people with COVID-19 infections moving between healthcare facilities or other places where there's many people living at the same time, there could be larger outbreaks. Going along to the next slide, which is slide 10, you'll see the curves that look at the different countries that Dr. Donnelly's already talked to. I just want to lay out that, the Ontario curve is shorter because of a shorter period of experience with the disease. But that point way on the far point there of a significant number of deaths, almost 100,000 deaths, is an estimate of what we might be looking at within 30 days had we not taken the initial measures. And I talk about what this case would be like had we not taken measures, because I think it's important to convey the seriousness of the threat presented by COVID-19, and also the issue that were we to relax or to assume that we were in safe territory now, this is a disease that can rear back very quickly. But you can see here 100,000 cases within 30 days had we not done anything. If you go to slide 11, you'll see a little more clear representation of this. The 300,000 cases with a lot of growth right there. The current intervention, what we mean there in the middle is that there is a substantial reduction given our public health interventions in place, but perhaps still about 80,000 cases that we might see if the disease continues to grow as it does in other jurisdictions. But looking at cases here, 12,500 roughly cases we'd expect by the end of the month if we take new enhanced measures to suppress the disease. If you go on to slide 12, you'll see a similar presentation of deaths here. Had we taken no action, again, even within the short 30-day period between here and now, you'd be looking at up to 6,000 deaths. Thankfully, there have been some actions taken, and this leads us to a current estimate of about 1,600 deaths. So a substantial reduction in the number of deaths over the month of April. But were we to put in significant, actually I misspoke, 1,600 deaths that would have occurred from cases that developed during the month of April. But were we to take strong action now, the number of deaths that we'd be looking at from cases that developed during the month of April would be much lower, at around 250 in the future intervention. With that, I'll turn it back over to Dr. Donnelly.
Steny, thank you. Ladies and gentlemen, as Steny has correctly pointed out, projections and modeling of a brand new viral disease are very inexact. But what is important is that we use them early and quickly to advise us as to the correct measures to take, and that is what has happened in Ontario. I want to turn now to perhaps what might be the most disturbing slide in this deck for those who have the deck to hand, and that is the slide which is on page 13. I think it's important that we all are robustly realistic about the scale of the challenge that we face. And what this slide shows is the projection by Public Health Ontario, which is in line with that of other highly credible modelers, that says that over the full course of this pandemic, which may last for 18 months or even 2 years, because we may have a smaller secondary or tertiary wave over the full 2-year course of the pandemic, Had we done nothing, Ontario may have suffered 100,000 deaths. Thankfully, that is not the position that we are in. Because of the very detailed actions that I read out to you before, which have been taken in response to emerging science, we believe that if we do all that we can get a much better end result for the province. It is not possible to be exact about where we will end up. But I think it is reasonable to say that if we do everything that we can think of, everything that already has been done stays in place, all of the other measures which are being considered put in place, that I think we could reduce the death toll in Ontario to somewhere between 3,000 and 15,000. There is a range because where we end up depends on all of us. If we follow the rules, if we do our best to socially distance, if we look after the elderly and the vulnerable in our society, we can get within that range and we can strive to get as low as possible within that range. So I appreciate that to many people, these will be shocking figures. But the important thing to stress again is that effective actions have been put in place, remain in place, and further actions are being proposed and are being taken. Now, we need to turn at this point to the important issue of all of the preparedness work which has been going on within Ontario Health Services. So I'm going to turn to Matt Anderson from Ontario Health.
Thank you, Dr. Donnelly. Good afternoon, everyone. For those who are following with the slides, I have one slide, and this is the slide on ICU capacity in Ontario. We use this slide as I think we all know, there are many different components to our health system. It is a very big system. This is a bellwether measure for us as we think about how do we get a sense of our preparedness and our readiness for this pandemic within our healthcare system. So the ICU capacity is a good measure for us. If you don't have the slide, what this describes is two curves, much like you saw from Dr. Donnelly and Dr. Brown. This is a slightly different data set because we update this every day, so tomorrow's numbers will be different than today's. But we do look at, do we have the capacity in our system to be able to support the people who are going to need our wonderful healthcare system? Right now, and what you would see if you have the slide is there's two lines on there. One is the amount of capacity we have in our system today. The other is the amount of capacity that we can surge to today. We continue to try to move that second line up. We want to get as much capacity in our healthcare system as we can develop in the very short time periods that we're discussing. There are two bar charts, however, on this slide that are most telling. The first one, which is in blue, shows that is our best case scenario given the data that we have at the moment, given the projections that you've just heard from Dr. Donnelly and Dr. Brown. And what's core about that is that that line brushes right up against what we are able to expand our healthcare system to today, at least as it relates to critical care capacity. The other bar chart is what happens if we do not adhere to our social distancing. And if we start down the paths that you've heard described between Dr. Donnelly and Dr. Brown of not containing this disease and this disease growing more rapidly, and what you can see from the slides is fairly soon in the April to sort of early May timeframe, it'll push beyond the capacity that we can bring. I would say that both on ICU capacity and on the entire system, your healthcare system all of our wonderful people who work in it, we are trying everything we can to continue to increase the capacity that we have to respond to this disease. However, as you've already heard, we need everyone to play their part. We have to try to keep the prevalence of this disease to a minimum to allow our healthcare system to be able to support those who need it. Thank you.
Matt, thank you. Just 2 more slides from me, and then we'll pause and take your questions. So people ask how one slows the spread. And I need to introduce you to what sounds like a complicated concept, but really is not. It's the so-called reproductive number, or the effective reproductive number of this virus. And it's actually a lot simpler than it sounds, but it's worth thinking about, because I think it helps us all understand what we should do. So if I was sitting here with COVID and I managed to give it to my 2 colleagues, that would mean that I had contributed to a reproductive number of 2. And if they then gave it to 2 colleagues again, you can very quickly see how the disease continues to grow at pace. If, on the other hand, my 2 colleagues both had COVID, but through proper social distancing and proper hand hygiene, etc., they managed, one of them to give it nobody and one just to give to me, you can see that the reproductive number then is less than 1, it's 0.5. And of course, what happens then is that the disease begins to peter out. So it's about breaking the chain of infection. And it's very important that every one of us realize that we have a personal responsibility and a personal opportunity to do that. So we need people to stay home, to stay focused, to stop the spread, and to stay safe. Everybody needs to fully adhere to the public health measures that are put in place, because we want to avoid overwhelming the health service in the way that Matt has just described, and the way that tragically you will see reported on the news media from around the world. So bearing down heavily on this disease now saves lives, allows our health system to cope, and also helps the economy. And this is not widely recognized, but is important. There is convincing research that suggests that if you bear down hard at this point, it actually brings the disease to an end more quickly, and it allows the economy to bounce back. So there is no dilemma between saving lives and saving the economy. Bearing down hard now achieves both things. Finally, I need to run through a number of immediate focus, additional public health measures, and also future measures which are coming. So the first thing that is very much being worked on as we speak is enhanced capacity for case and contact tracing. In jurisdictions elsewhere in the world that have done particularly well, this has been very important. It's about breaking the chain by assertively chasing down cases and their contacts. There is a small army of federal employees, medical students, and others being assembled to actually address this issue. They will be working closely with Public Health Ontario, with the Ministry of Health, with Ontario Health, but particularly with the public health units in the province. The second thing is increased testing due to very impressive efforts by frontline lab staff and lab leadership, not just at Public Health Ontario, but across the province in many of our hospitals. We have now eliminated the backlog of tests. That is important because that now allows us to use tests in a very focused and strategic way. For example, Testing residents of long-term care homes and their carers needs to be a priority. As we have tragically seen, if you get even one case in a long-term care home, it is very easy for it to spread very quickly and to bring about many deaths. So we need to use our testing strategically to protect the elderly and the vulnerable. We need to use our testing strategically to protect healthcare workers, to protect our hospitals, to track symptomatic contacts of cases, and taken as a whole, we need to use testing as a subcomponent of our strategy to drive down the infection. Future measures include the further reduction in the number and types of essential workplaces. This has to be done carefully, and everybody understands this, I think. Those who would cry, simply shut everything down, need to remember that we need our nurses and doctors and healthcare workers to get to work. We need our laboratory workers to get to the labs, and we need transport to operate to get people there. The public need to be able to get groceries, pharmacy supplies, and other essentials of life. So reducing the number and types of essential workplaces is something that needs to be done carefully and thoughtfully. There will be an enhanced focus on enforcement and fines for non-compliance. Physical distancing guidelines will be further enhanced, particularly with regard to retail settings. It is essential that we provide enhanced support for the elderly, for the homeless, for vulnerable populations, and for communities. The concept of a ring of steel around long-term care homes is important. I applaud those jurisdictions who have proactively moved to house the homeless in accommodation which may prove life-saving. Many First Nations communities are looking very carefully about overcrowding in housing, and again, I welcome the approach that some public health units have taken in working with First Nations to reduce overcrowding and therefore to reduce vulnerability. Some First Nations are looking at entry restrictions to their territory. Human resource management is going to continue to be important. We have to protect our healthcare workers. We have to allow them to look after us. We are exploring rapidly use of technology to reinforce self-isolation, including, for example, alerts, and additional public education and communication will be forthcoming. Once again, in summary, and then I will stop for your questions to any of the three of us, we need to bear down heavily on this disease now because it will save lives, it will allow our healthcare system to cope, and ultimately it will be the best way to help our economy bounce back. I'm happy at that point to pause, and we will do our best to answer any questions you might have.
Okay, so just a reminder for everyone